The general purposes of the pediatric prophylaxis are to eliminate plaque with the intent that it will assist in the prevention of caries and periodontal disease, cleanse the teeth for improved topical action of fluoride, and offer a child a simple, non-traumatic approach to chairside dentistry. The dentist should explain prophylaxis armamentarium to the child patient to relieve any anxiety the child might develop upon viewing strange, shiny, sharp objects. The armamentarium or tray setup requires an explorer, a mouth mirror, cotton pliers, a superficial universal scaler, which is optional, a prophy angle, dental floss, and 2 disclosing tablets, fluoride, prophy paste, patient towel, small and large suction tip, and a toothbrush, and some gauze. The patient's mouth should be examined for any local or systemic factors that may influence periodontal disease in children. The following list is introduced only as a guideline. Physiological changes associated with tooth eruption, pre-eruptive bulge, formation of the gingival margin, normal prominence of the gingival margin, gingival disease, chronic marginal gingivitis, local gingival recession, acute gingival infections, acute herpetic gingival stomatitis, monolysis, thrush, acute necrotizing ulcerative gingivitis, periodontal disease, periodontitis, advanced alveolar bone loss in adolescents, palmoplantar hypokeratosis with premature periodontal destruction, periodontosis, papillon-Leverfrom syndrome, severe idiopathic periodontal destruction in children, precocious advanced alveolar atrophy, traumatic changes in the periodontium, oral manifestations of systemic disease, Down syndrome, dilatant hyperplasia, gingival fibromatosis, puberty gingivitis, diabetes, immunodeficiency disorders, blood dyscrasias, malnutrition. Plaque and calculus removal. Remember to remove any appliances that your patient might be wearing before beginning your prophylaxis. Next, take into account the comprehension level of the patient. You should, in appropriate language, introduce the child to the steps in the prophylaxis by the show and tell method. First, instruct the patient to chew a disclosing wafer. With very young children or those with disabilities, a cotton applicator dipped in disclosing solution may be applied to the teeth. After having the patient rinse with water, you should examine the teeth for areas of plaque accumulation and calculus deposits. The most frequent area of calculus deposit accumulation is the lingual surface of the mandibular incisors. Where gross calculus deposits are seen after disclosing, the operator should proceed to remove the hard deposits with a universal superficial scaler. To avoid nicking the teeth and surrounding tissues, these instruments are activated at an angle of slightly less than 90 degrees with the tooth surface. The cutting edge engages the supragingival calculus at the level of the crest of the gingival margin, and the calculus is dislodged with a firm, steady motion upward toward the crown. The procedure is systematically repeated until all the visible calculus is removed. When you are ready to begin the prophylaxis, the prophy angle is placed on the low-speed handpiece and the rubber prophy cup is attached. The cup is dipped into the prophylaxis paste. A saliva ejector should be used to remove excess saliva so the patient does not need to expectorate frequently. With gentle pressure, the prophylaxis cup should be placed under the buccal or facial free gingival margin. Keep in mind that the depth of the gingival sulcus in a child is 2.1 millimeters plus or minus 0.2. Having placed the prophy angle accurately, you should now rotate the cup mesial-distally as you move toward the buccal incisal surface. Then proceed to cleanse the occlusal surface. Finally, moving to the lingual surface, cleanse the lingual gingival sulcus last. Make sure that you do not overlook cleaning the interproximal embrasures. When all the surfaces have been polished and before rinsing the mouth, use dental floss to pull prophy paste into the interproximal surfaces. It is recommended that the remaining disclosing wafer now be used to check for any areas omitted during the prophylaxis. The patient is now ready for the fluoride treatment. The technique for the clinical fluoride therapy. There are two suitable techniques we use for clinical fluoride therapy. One, the double rinse technique, which is best. First, dispense 1 ounce of APF, the red solution, into a plastic cup, 1 squirt of the plunger. Second, dispense 1/2 ounce of the stannous fluoride, the tan solution, into the second plastic cup, 1 squirt of the plunger. Dilute with 1 ounce of water just prior to use. Third, have the patient rinse 1 minute with 1/2 of the red solution. This is followed with 1 minute rinse of the remaining APF. Fourth, immediately have the patient rinse 1 minute with 1/2 of the 0.4 stannous fluoride solution. This is followed by a 1 minute rinse with the remaining stannous fluoride solution. The patient should not rinse or eat for 30 minutes after the treatment. Routine dental procedures may be performed immediately. When the quadrants of the teeth are isolated and the fluorides topically applied, the same time limits are applicable. The single rinse technique, which is acceptable. First, dispense solutions as above. Have the patient rinse 1 full minute with the entire APF solution. Immediately have the patient rinse 1 full minute with the 0.4 stannous fluoride solution. The patient should not rinse or eat for 30 minutes following the procedure. Routine dental procedures may be performed immediately. Note, it is very important that 1 full minute be allowed for each rinse, otherwise the protection loss will be greater than 10%.